Welcome again. Everybody doing all right? Any dying questions about your test this morning? And you all passed, so it shouldn't happen. Right? You guys already forgot about it? You're like, whatever. I didn't remember taking a test this morning. All right. We're going to move into ocular ultrasound today. So we're going to be practicing on our ocular ultrasounds. I'll try to give a demonstration up here, but the slides do pretty well. We've got a couple. I brought a couple more machines out this time, so we should have more, less people per station doing it. I think we'll need to clear off like a desk for somebody to lay on and move one of the machines up to it. It'll probably be the easiest. So whoever wants to volunteer as tribute or move their stuff or anything will probably be easy. We'll need to plug by, but I think I'll let you do that plug. All right. Man, it's Friday. Woo. You guys have a class after me, right? No. Oh, shoot. Well, let's get done then, man. All right, so we're going to do the ocular ultrasound today. So it's quick, it's easy. You just need, the key to it is tons of gel. The more gel, the merrier. We want to put a nice little pad in between their eye and the ultrasound probe. And we use these for really any eye complaints, but a lot of times trauma we can use them for. We can use them for like foreign bodies, if anybody got anything in the eye. We're really looking for retinal detachments, foreign bodies, vitreous detachments, and we'll get into the details in just a second. We're also going to look at the optic nerve sheath diameter. So we measure that, we say 3 by 5, and that's 3 millimeters back from the retina, and then we measure across, and if it's less than 5 or less is considered normal. All right, let's keep going. So here's our indications. So vision loss, changes, flashes, floaters, any acute eye pain, trauma, foreign bodies. We can look at elevated intracranial pressure, measuring that optic nerve sheath diameter. Some of the times we don't do it are globe ruptures. So if we suspect a globe rupture, we don't want to put an ultrasound probe on there or any pressure. So these are times we would defer their intraocular pressure. And even if we consider a globe rupture, we're not going to do an ultrasound on it if we have any concerns. All right. That eye does not look good. I had a globe rupture a little while ago. Somebody was using a weed eater, wasn't wearing glasses, and a piece of grass went all the way through his cornea and into his eye. It was horrible. He didn't have insurance and he wanted to leave, and we were like, dude, you're going to lose that eye if we don't get you to the ophthalmologist right now. He actually listened to us, one of the few. All right, so the advantages. It's easy, it's portable, non-invasive, no radiation. Same thing for basically all point-of-care ultrasound testing we're doing. But what's the clinical question? Why are we doing this? So one, we're looking for any widening or papilledema or increase in that optic nerve sheath diameter. So that could be, signs of increased ICP from head trauma. What are some other things that would cause papilledema? You guys remember? Yeah, I think I heard somebody say it. Yeah, benign, intracranial, whatever the rest of it is. Yep. Cranial hypertension. Yep. Yes. Or it's easier to remember as pseudotumor cerebri, but I guess that offended somebody. I don't know. All right. Is there a retinal detachment? Do we have a vitreous detachment, hemorrhage? Is there a foreign body? And then is the lens dislocated? So those are some of the questions we have that we're looking at. And really we're just trying to find out what's causing that eye pain, those flashes, floaters, or anything else. This will make more sense once we go through the slides a little bit more and we have it at the end. But this is basically this is what you kind of see on the dark ultrasound screen. You see certain conditions. You'll see for the retinal detachment, you'll have those little wispy lines there. The vitreous detachment, you'll see that highlighted portion kind of moved up from the retina, so something basically detached from the retina. We got vitreous hemorrhage, so you'll see that washing machine sign. And then the central retinal artery occlusion is a little bit harder to see, so you're going to have a lesion there in your, occluding your retinal artery, so it'll be down in your optic nerve sheath or at the back of the eye in the retina where you would normally see the optic nerve sheath. And then we have it for traumatic and painless vision loss. Foreign bodies will light up depending on what they are. So if it's a piece of metal, it's very easy to see. And a lot of times, obviously the guy with the grass wasn't a piece of metal, but a lot of times people are working on metal, you'll get that small fragment. And sometimes people don't even know something went in their eye. So we have to have a suspicion like, well, he's kind of got some irritation in his eye, he was hammering something, or he was using a grinder, or a lot of people are using a grinder, whatever it is. So then we can further evaluate and kind of rest a little bit more assured that something didn't penetrate through his eye. All right, so preparation. How do we do this? So we want the patient supine. I wouldn't use a tegaderm patch. I mean, if you become good at it, proficient, and it works, fine. You just don't get as great of an image because you're placing something else between the eye. And it's hard to get a seal without the air in there. So the air under there is going to kind of mess up your image. So that's usually what the problem is with it. We need a ton of gel, so you want to create the giant gel pad above their eye. And then we're using that little, the linear probe. So it's going to be the little bit longer, skinnier probe on there. And then we want to change it to the ocular settings. I meant to Google it. Somebody was, I don't know if they just said in training, like, you can damage their eye if you use the wrong setting or the other probes. I don't know if that's true. I meant to look that up, actually. Somebody can Google that real quick. All right. We're using a transverse and a sagittal. So one of them's going transverse across, and then one of them's going up and down on there, okay? And then the key to this is having an anchor. Do you see how their fingers are anchored on something? I saw a lot of you guys not anchoring your fingers. This one's extremely important because it's a small area we're evaluating. So any little movement with our hand, if it's not anchored, is going to throw off your image, and you're going to sit there struggling forever. You're going to be like, well, I can't get it. And I'm going to say, well, use your little kickstand or anchor. If I can get to the head of the bed, I usually just stick my hand on the forehead and do it backwards on there and move my machine. But it's all up to shooter's preference. Just make sure you have an anchor on there, or else you're going to struggle for a while. And I'll let you. All right, let's look at some anatomy here. So what we're seeing here, and this is like a perfect image here. So you got your eyelid out in the front there, and then you got anterior chamber, iris, you got your lens, and then you got your vitreous body, retina, and then your optic nerve. So that's what we're looking for. That's what our images should look like, okay? And some of you will struggle because your angle may be a little off and you might have to slide it a little bit out. They usually say like 15 degrees or rocket 15 degrees. But this is how it should look on your images, okay? If you don't see all that, then you probably need to continue searching or adjusting your position on there. And then there's the optic nerve. So that's what we should see in the back of the eye. And this is probably what you guys are going to struggle the most with, is finding that optic nerve back there. Ideally, we use the transverse view, is like the standard way we're supposed to acquire that image. And it should look like you see all your anatomy up there. So you see, well, you don't see you see the anterior chamber not as well, and the eyelid there, but you see that. You see the lens, the iris, posterior chamber. So that's good, and that'll give you the ideal measurement on there when you're trying to get it. Remember on those machines, if you hit that little snowflake button, you can go back and forth. So make sure when you're doing this, make sure your hands, when you're trying to get the optic nerve sheath diameter, make sure your hands by it so you can hit it real quick, because it might come in and out real quick, and then you can scroll back a little bit and it'll go in time, and then you can stop it there and measure, okay? All right, here's what it should look like. So one of the things we're going to be doing is you want them to move their eyes so we can make sure we're evaluating the entire globe. So we're wanting to look at everything in there. So when you're transverse, you have them look medial, lateral, right and left. And then when you're sagittal, you have them look up and down, okay? All right, here it is. Apply your gel, get your right probe. And then one of the, I thought it was on slide, but maybe not. So sometimes we want to increase our gain so that we can see so we can evaluate the retina and the optic nerve sheath diameter better. So you see it's lit up a little bit more back there. So sometimes you may have to up your gain a little bit so that image isn't dark. All right, so here we go. We anchor the probe. We rotate it 90 degrees. You can, easy way to rest on the bridge of the nose. On the left side, you can, rest it on the zygomatic arch. Sometimes, if you can get to the head of the bed, it's easy to rest your hand on their forehead. Might help. But then you're backwards, so you gotta reverse everything in your mind. All right. So this is what I was saying. Sometimes you might, to get that optic nerve sheath diameter, you may have like a perfect shot, or you may see your anatomy appropriately, but you can't visualize optic nerve. So you might have to rock it, just, turn your hand a little bit to the side, like 15 degrees, and hopefully it comes into view and you get a good image. You see those little X's on there. So the two middle X's, that should be 3 millimeters. So you want to measure 3 millimeters back, and then you measure across. Yep, so transverse view, and then once you get the perfect image, click your little calipers, measure 3 back, click them again, measure, hopefully it's less than 5. And then there's another picture on there. All right, and the optic nerve sheath diameter of less than 5 is like an ICP that should be under 20. All right, so there's another picture and a measurement that we're doing. So we want to measure that 3 millimeters back and then measure across right at that X. Good. So that's showing another measurement there. That one's 0.6A, so that's abnormal. It's increased. Not the best image of it though. So like it's hard to evaluate the like the actual walls of that optic nerve, but that's being generous. So like if that's the only image you can get, then you want to err on the side of it's larger than, oh, everything's fine, it's normal. But that one would be a little bit difficult when you're trying to find where the optic nerve, the wall of it is. All right, so here's what we're looking for. So we're looking for retinal detachment. So this can cause permanent vision loss. That's why we're most concerned with retinal detachment for these. And that really is some sort of fluid. Something got behind the retina and it detaches it from the wall. And they'll have to do, emergency surgery for that, if you want to call it surgery. I mean, it's like eye stuff. So they, I think, use all kinds of different techniques and lasers and other things to tack it back down in there to help you. And for almost all of these, a lot of it, like the posterior vitreous detachments, if I can speak, and retinal detachments, and almost everything like diabetics, are going to be a lot of the common ones you see it in. Also, retinal detachments happen as we get older, same with the vitreous detachments, which the vitreous is probably the more common one you see on here after probably, foreign bodies. This is what it should look like. So your retina's attached there around that optic nerve sheath, so that's why you kind of see it still attached right before it, and that's how most of them look. There are ones that aren't attached, but they're less common. But it'll look like this little wispy line in there. All right, next we got the vitreous detachment. So this is separates from the retina. We get fluid behind it. You see it a lot in diabetics. We see it as we age. There's other, autoimmune conditions you might see it in. But you'll see that like hyperechoic membrane, not tethered to the optic nerve. Looks like seaweed, like swaying seaweed. All right, here's another picture of it. So you kind of just see that little movement like it's floating in there, and when you do your extraocular movements, you'll kind of see it wave around like that seaweed. All right, so here's our different treatments. So retinal detachment, that's an ocular emergency. We need to call opto immediately. The vitreous detachment, not of an emergency. Both of them can present with vision loss. So they can both present with flashes, floaters, and all of that. Retinal is more commonly associated with like trauma, but it also happens with age as well and comorbidities. All right, next we have hemorrhage, so it's extravasated blood inside or around the vitreous humor. So these patients may complain of like red swirling in their vision. They might have flashes and floaters, but we call it the washing machine sign. Let's see if we can get a good image of it. So here we go, yeah. So you got that like hyperechoic fluid back there. You see it move around. It's not like a well delineated line. It's just, a mixture of fluid in there. All right. So the goal is we start scan today. The The gel is, water soluble. It doesn't hurt your eye. It doesn't, I don't think it really burns. So, after you guys perform it, you can go wash your eyes or whatever. Sometimes you don't have to. It's going to be up to you guys. It's not going to cause like any chemical irritation or burns or anything like that, okay? What is something we want to know before we do this for patients? Like read my mind? Yeah, you have contacts in, so we definitely want to know if there's contacts in there. So if you're wearing contacts, either take them out or don't have one done on you. What questions y'all got?
They've had LASIK or PRK or anything? Is that make a difference? No. You can see it?
No. The only thing, so there are those like intraocular lenses, or I can't remember what the name of the procedure is, but that's one of the procedures they use frequently now, is to actually place a different lens in there. I don't recall whether, I think it doesn't look any different, but it's possible, I don't know. All right, there's another little picture there. All right. Oh, sorry, there's CRAO too, so you see that little light spot, that like hyperdensity back there. This is not as I've never seen this. But that's something that you may be able to diagnose with this. Really, we're going to need the ophthalmologist to diagnose this, but you might be able to see that hyperphilic area there in the optic nerve. All right. Well, we're going to get the scan in. Do you guys want me to do a demonstration, or you guys will start practicing?
Demo.
A demo? All right. Let me get demonstrator up here.
I'll volunteer for.
Take one for the team.
Tell me what it feels like.
He just wants to lay down and close his eyes.
Yeah, he just wants to take a nap.
Yeah, badly.
Let me get this off. Whoa!
Not the dumpster fire.
I broke your dumpster fires. Sorry.
We've been broken, sir.
That's why we can't have nice things.
It's like my spirit.
It's